Okay, Dr. Apinun, if you can please start us off. Thank you very much.
Okay. Hello, everyone. Thank you for joining and welcome to class Connect Foot and Ankle, organized by CONMED. My name is Dr. Jirun Apinun from Thailand. We have 3 topics being presented today on the foot and ankle, which will be followed by a joint 15 minutes Q&A session. Please type in your questions in the chat or at the question box on the right, and we will answer them at the end of the webinar. Before we start, I'd like to introduce the other members of today's panel. First, we have Dr. Gopal from Malaysia, who will be presenting his approach to lateral ankle instability. Then Dr. Jinsu Kim from Korea will present his topic of acute ankle ligament repair. Okay, I will start with my topic about the approach to on ankle instability first. Okay. Okay, next slide, please. Okay, about the chronic ankle instability, about around 20% of acute ankle sprains develop the chronic instability, and because the acute ankle sprain is really very common injury in sports injury, so chronic ankle instability is quite have a high amount in population. The presentation of patient can come with giving way or recurrent sprain or functional disability. The other symptoms are pain, swelling, or fatigue. The predictors of becoming chronic ankle instability is the level of activity. If the patient has a high level of activity, there's higher chance of chronic ankle instability to develop. Lower limb malalignment or limitation of ankle dorsiflexion or generalized ligamentous laxity and ankle joint pathology or elevated BMI can also be the predictors of chronic ankle instability to develop. The next slide, please. Okay. In chronic ankle instabilities, up to 96.9% can have associated injuries. For example, osteochondral lesion, peroneal tendon pathology, either tenosynovitis, tendon tear, or instability of the tendon. Combined ligament injuries, up to 72%, there are deltoid ligament injuries, and also syndesmotic injury must not be overlooked. Impingement, either bony or soft tissue impingement, subtalar instability, or synovitis, loose bodies, or tenosynovitis of posterior tibial tendon can also be detected in chronic unstable ankle. Okay, next slide, please. Okay. The chronic unstable ankle can be divided to the mechanical one and the functional one. The mechanical one can be resulted from laxity of the ligament or the pathology of the joint, such as synovitis, impingement, or osteochondral lesion. The functional instabilities usually resulted from deficit of proprioception or muscle strength. Also, the gastrocnemius contracture can play a role as well. Next slide, please. Okay. We back to the anatomy. Now, the lateral ankle ligament in recent publications by Jordi Vega, the dissection found the superior fascicle of ATFL to become the the isolated one. This is the intra-articular structure lacks in ankle dorsiflexion and taught in ankle plantar flexion. And the inferior fascicle of ATFL and CFL, they both are extra-articular structure connected together with the arciform fibers and isometric. So they both, these two ligaments work together to stabilize both ankle and subtalar joint, and the talocalcaneal ligament is probably a part of this complex. And the author term the lateral ankle ligament as a lateral fibulo-talocalcaneal ligament complex. Okay, next slide, please. Okay. About the mechanics of unstable ankle, it's not only the translation or the tilting, but it's the rotational one. The instability developed because of the increased external rotation of the leg, and inversion is made by the external rotation of the leg. So the mechanical instability, there is a talar tilt, but for the functional instability, it may be resulted from increased inversion, but there might be no obvious talar tilt or subtalar gapping shown in the stress radiograph. Okay, next slide, please. Okay. And also the concept of micro instability developed. This is the condition that the superior fascicle of ATFL is torn, and the patients presented with recurrent ankle sprain and feeling of instability. There's also the anterolateral ankle pain. However, from examination, there will be no laxity shown except the subtle anterior translation compared to the contralateral side. And MRI may not be sensitive enough for detection, and this micro instability can cause the patient to have symptoms and make them have to progress to the further intra-articular pathology. Next slide, please. Okay, they divided the micro instability into many types according to the morphology of the ATFL pathology, which may lead to different treatment. Okay, next slide, please. Okay, the subtalar instability is the other one that we need to identify, because 25% of the lateral ankle instability has subtalar joint instability in combination as well. It's resulted from injury to the CFL and interosseous talocalcaneal ligament. We can diagnose this condition from the presentation as a giving way instability or the sinus chassis syndrome, which is a pain and swelling at the subtalar joint. The examination can be detected from anterolateral drawer test, which is anterior drawer with inversion of the high foot as well, and we can feel the gliding of the calcaneus between the calcaneus and subtalar joint. The subtalar gapping can be shown in the stress radiograph. The surgical treatment can be done by the brainstorm gold or the anatomic reconstruction of ITCL or non-anatomic reconstruction by Emsley or Christman-Stubb to stabilize the subtalar joint. However, the non-anatomic one is not popular because of the complications and over-constrained stiffness and leading to osteoarthritis. Next slide, please. Okay, the diagnosis of chronic unstable ankle started from history. We must ask the history of injury from the patient about the symptom of recurrent sprain, the giving way pain, and level of activity and functional disability that is affected. The examination, we must test the stability of the ankle, both on the lateral side, the medial side, and also the syndesmosis, and also the subtalar stability. We need to examine the tenderness around the ankle joint to find the associated intra-articular pathology, assess the range of motion if there is any impingement, limit the dorsiflexion, or the gastrocnemius contracture that we may need to correct as well. The peroneal tendon strength or the pathology that can be hidden. The single leg balance or the Romberg test to test the functional and the proprioception of the patient. And one of the most important thing is the generalized ligamentous laxity. Okay, next slide, please. Okay, the radiograph, the weight-bearing film is the standard one. The stress radiograph, even there is a high specificity, but because of low sensitivity, so the value of its use is limited because it's have diagnostic value only if they are positive. The dynamic ultrasound can show the laxity of the ankle ligament well. However, it's operator dependent and need the experienced one to show it. The MRI is high specificity and has a positive predictive value for the ligamentous lesion, and it can be used for the assessment of associated pathology. However, there is a low sensitivity from MRI. Next slide, please. Okay, so this shows the diagnostic test, which has you can see that from clinical, the sensitivity and specificity is around 70 to 80%, which is usually we diagnose from clinical examination, and then we use MRI or after investigations to confirm it. Okay, next slide, please. Okay, for conservative treatment, we can use orthotics or heel wedge, such as heel wedge or ankle brace, and send them for rehabilitation. However, only 50% of patients can be benefited from rehabilitation program, and the mechanical instability is less likely to benefit from conservative treatment, and we may consider earlier surgery in this group of patients. Next slide, please. Okay, the surgery option can be the anatomic ligament repair, which is proposed by Brastrom, and can be reinforced by extensor retinaculum proposed by Good, by periosteum, or by synthetic, such as suture tape. However, in the patient with generalized ligamentous laxity or with poor remnant of ligament or has a high risk patient, we may need to perform the anatomic ligament reconstruction by autograft harvested from plantar wrist or hamstring tendons. Or we can use allograft. However, we don't have a allograft in Thailand yet. The non-anatomic ligament reconstruction can be used as a second line after a failed anatomic repair or reconstruction. However, it has less popularity now because of the problem that I mentioned before, arthritic change and over-constraint and stiffness of the ankle. Next slide, please. Okay, yeah, this is many kinds of non-anatomic ligament reconstruction. Okay, we can pass it. Next slide, please. Okay, the role of arthroscopy in surgery of unstable ankle. The arthroscopy has a role in treatment of associated lesion intra-articularly, such as osteochondral lesion or impingement. It can also assess the ATFL remnant quality if it's poor or good enough to be repaired, or we need a reconstruction. We can, in the micro instability Vega type 1, which is just the attenuation of the superior fascicle of ATFL, we can perform like a small, like a thermal shrinkage without formal repair of it. And it can, nowadays there's recent advancement in arthroscopic stabilization, either repair or reconstruction, which has a comparable result with the open procedure, and it can make them early rehabilitation and return to daily activities. However, we need to consider to work only in the internervous and intertendinous safe zones to avoid nerve and tendon injuries. Next slide, please. Okay. Okay. We also need to address the malalignment and correct it. The predisposing factor for the instability is a varus high foot, which can be the supramalleolar or the varus foot. Sometimes it's not easy to convince the patient to have a alignment correction. However, with the advancement of minimally invasive or percutaneous surgery, we can correct the varus foot easier with the small burr and percutaneous screw. Okay, next slide, please. Okay, so in summary, my approach for chronic unstable ankle, at first, for the diagnosis, we need to examine truly to identify and search for mechanical. Is it the mechanical or functional one? Is there subtalar instability? Or combined other ligament injury as well? Is there any intra-articular associated? We need to address the malalignment and generalized hyperlaxity condition, which is really the important determinant for the treatment. For the investigations, usually I prefer the weight-bearing radiograph of ankle and also the lower limb alignment to check, and the MRI for assess the quality of the ligament and also to identify the associated pathology. The stress radiograph, I use it infrequently, only in some exceptional cases. For example, in really obese patient that I cannot feel the from examination well. Okay, next slide, please. For the surgery, when should we perform the surgery on this patient? We should start with the non-surgical treatment always, at least for 3 to 6 months. However, in the mechanical instability or associated pathology, we may consider surgery earlier. Okay. Should we do the arthroscope in these patients? If the patient is pain-free and no pathology shown in MRI, then we may not need to perform arthroscopy in this case. However, if the patient has pain or associated pathology or the microinstability is suspected, or if arthroscopic repair is planned. However, I am really selective for the patient with the arthroscopic repair. I choose the one which are without much lateral and with no the subtalar instability, because arthroscopic repair can repair only the superior fascicle of the ATFL. The ligament remnant must be in a good condition, which is assessed from MRI preoperatively and again intraoperatively. Look at it. If it's in a good condition, then we can perform it. And the patient must not be the high-risk patient. Must have no generalized ligament laxity. Must have no high BMI, or it's not the revision cases. Okay, next slide, please. Okay. And for the repair or reconstruction, my first choice is still modify brainstorm groove with the periosteal flap augmentation. However, in a higher risk case, I consider the reconstruction with hamstring graft or augment it with the suture tape. Next slide, please. Okay, this is the video of my arthroscopic brainstorm repair. Okay, could you please play the video, please? Okay. We can see that the attachment of ligament is really detached, and the quality is not it's still okay, but it look like the hammock underneath is fall down. So I use the suture, put the suture as a shuttle first, try to grab the thick the thick tissue as much as I can. The video doesn't run well. Don't know if others look like me. Yeah. Okay. After we can put the suture through, we grab both limbs of suture through the same portal, just to make sure that there's no any outside tissue to obstruct our knot tying. Okay. 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 I put 2 points of suture. Okay. The other one. Okay. Okay. After I have the 2 suture chapters, then the next step, I put the suture anchor into the insertion of fibula. Okay, now the suture anchor comes here. Sorry to take your time. Okay, and then I switch the suture shutter with the suture from the anchor, and then tie the knot. Because we don't have a knotless here. Okay, and the final construct, you can see 2 of the knot and the ligament attached to the distal fibula already. Okay, next slide, please. Okay, for the cases, I use the open method. If we need a stronger construct, assess from arthroscopically. Okay, could you please play the video, please? Okay, in this case, the ligament is absent. Okay. Then I dissect the periosteum up and fold it down to make it as a one whole flap of the periosteum and ligament. Okay. Then prepare the distal fibula. Okay. Also dissect the extensor retinaculum. And I put two suture anchors into the distal fibula. Try to replicate the ATFL and CFL. Then we set the position of the ankle, tighten the ligament, and suture it back to the insertion. Then reinforce it with the extensor retinaculum. Okay, tie it, and now extensor retinaculum is attached to the construct as well. Then at last, I flip the periosteal flap down to augment the whole construct, and also to cover all the suture knot to reduce the irritation. Okay. That's it. Okay, next slide, please. Okay, for post-operative care, I put the patient in the splint and elevate his limb for 2 weeks. After 2 weeks, we can switch to the walking boot and allow them to weight bearing as tolerated, and allow range of motion exercise in only ankle dorsiflexion and plantar flexion, no eversion or inversion yet. Okay, in 6 weeks, we can switch from the walking boot to ankle brace, and we allow for weight bearing and full range of motion exercise. Next slide, please. For return to play, the patient can return to training in 2 months. However, for the return to full play, it may take around 4 to 8 months. The criteria for return to play is no longer pain or swelling or instability. The RM and strength should be painless and normal, and the neuromuscular control should be restored. The ankle bracing will be used for at least 6 months to decrease the chance of recurrent ankle sprain. Okay, next slide, please. Okay, that's the end. Thank you very much. Okay, if you have any questions, could you please write it in the question box. Next, we will have Dr. Siva from Malaysia present on his topic.
Thank you, Dr. Apinun, for the talk. That was surely interesting for me to see, because I don't do arthroscopic at all. It's just purely open and rostrum. I heard technically it's quite demanding, and it's only used for certain cases. Thank you. I will start with my presentation. Slideshow. Can you see, please? Okay. Today's talk will be seen. A lot of it will be repetitive. Hope you all will bear through it. It's common. Ankle sprain constitute nearly 25% of all musculoskeletal injuries and almost 35% of all sports-related trauma. It's seen regularly in contact sport for 15% of all football injuries, and only coming in second to ACL.
Sorry, I can't see your presentation. See only your face. Yeah.
Oh, really? I'm so sorry. I'm sorry. Are we through?
Yeah, I can see it now. Yeah.
Sorry for the glitch. Okay, I'll go back again. So it contributes to almost 25% of all musculoskeletal injuries. Lateral ankle injury contributes almost to 80 to 90% of ankle ligamentous sports injuries. As for ATFL, it has got the lowest load failure at 140. It allows a good amount of plastic deformation before it tears, and it elongates during plantar flexion. As for the CFL, it's got the highest load before it fails at 345 newtons. It prevents hind foot adduction and it elongates during dorsiflexion. PTFL, least talked about, it has got restricts the ankle in external rotation during dorsiflexion, and it fails at about 261 newtons. And the other part which we need to pay attention is on the peroneal muscles and the tendon, which plays as a dynamic stabilizer for the ankle. This has to be assessed as well. This is a basic picture showing the anatomy of the AITFL, PITFL, ATFL, and CFL ligaments. The injury is based on a plant. They always give a history, almost commonly on a planted foot, weight bearing, and inversion injury. And the grade of swelling and pain depends on the swelling, as well as grade 1, grade 2, or grade 3. It's been graded by grade 1 being stable with no anterior drawer or lateral tilt. Grade 2 is stable. It's got a complete with partial CFL tear. It comes with a positive anterior drawer test, and the lateral tilt test can be negative. In grade 3 is the most unstable version. It's complete ATFL and CFL with a positive anterior drawer and lateral tilt test. And in grade 3, you also have to pay attention to the syndesmotic ligament, the anterior and the posterior syndesmotic, and as well to the peroneus tendons. Associated injuries, which common is osteochondral defects, peroneal tendon injuries, deltoid ligament injury, PTFL, and sometimes the fracture of the fifth metatarsal bone, depending on the severity. X-ray, I commonly, by day-to-day practice, if we come, I do an AP, lateral, weight bearing, long leg film, amortis to see for the syndesmotic ligament. If I do not have the Taylor's device, if you have, it's a good thing to have because you can actually see the Taylor tilt quite well. Our practice, we do have a radiologist who helps me with the ultrasound. And I find this very good in acute cases because it actually gives you a clear picture of the ATFL or CFL. It gives me a dynamic assessment of the injury and also to see how any other associated injuries. I don't do MRI in the beginning in acute cases because the swelling and also the capsular tear, the retinaculum tear sometimes mask, and I cannot see the ATFL because, as we know, the ATFL part of it is all superior and inferior portion. The inferior portion partly blends in with the retinaculum, so you cannot have a full access of the ATFL. And all the swelling does mask the MRI pictures and difficulties to be seen in acute settings. Management, I think, is classical for every cases we do. We do a rest, immobilization, ice compression, and elevation. I tend to do in acute cases, I brace them in a simple ankle brace. If it's grade 3, I still brace them first by using a pneumatic shoe, vacuum CLAAS, and we start partial weight bearing. Range of motion exercise started immediately. Proprioception training, do a lateral compartment specific training as well. Back to sports starts about 3 to 4 months. We start training them back to sports, and they go back to sports, full sport, after about 6 months. But they will have to wear the ankle sprain during this time in acute cases. Recurrence, however, I do get about almost 2.5 times of the patient, at least 2.5 times of the cases. In general, in poorly rehabilitated, I have problems with compliance. A lot of patients who do not wear the ankle sprain, when they feel better, they tend to forget about it. This leads to chronic pain and instability. And they will come in with simple, trivial injuries. They do get a lot of recurrent ankle sprains. In chronic, we face mechanical and functional instability. Functional is being defined as beyond voluntary control, but not necessarily exceeding the physiological range of movement. If they come with only functional stability, there is a good role of conservative management with good rehabilitation. You may get good stability for sedentary lifestyle people, but when active sportsmen, functional instability sometimes can give problems. Surgery might be indicated. In mechanical instability, which is defined as a motion beyond physiological limits of the ankle, especially with increased anterolateral instability. Here, in this kind of cases with mechanical instability, I generally do surgery for all these cases. Functional has got its own problems. They present always with tendinopathies due to the Taylor tilt and eversion of the ankle. They do on long term get chondral lesions, and they also present with some impingement pain. Mechanical instability generally come with ligamental tear instability because of the patella tilt as well as the eversion, and they have a lot of impingement, and chondral lesion is almost a must case in mechanical instability. This is a case I would like to share, which I just did recently. It's a 36-year-old lady who plays regular bowling. She plays about 3 times a week. she plays competitive for her company. 2018 to 2019, she sprained it 4 times. However, twice was poorly taken care of. And the other 2 times, she had splinting done. And due to the pandemic, 2019 to 20, she never played any games. And she went back to work on 2020, and she had another episode of instability. She came back, and this time I proceeded with surgery for her. Her clinical presented at the time was swelling. She complained a lot of instability during walking, especially in uneven places. She has to keep her foot in slight external rotation to prevent her ankle from giving way. Because of doing that, she always has got lateral compartment pain over the peroneal. She was tender over the peroneus brevis insertion, and as well as the tip of the fibula. She had a positive drawer centaurus tip. This was an ultrasound finding. This was an ultrasound finding. There was a tear over the ATFL. I hope the one on the right is a normal case where you can see clearly the ATFL, and here the ATFL is missing. We did an MRI for her. There is almost no ATFL. There's a gap seen clearly where the ATFL should be, and as we can see, the CFL is there's a lot of high signal pictures. So what did I do? My preferred choice, because I'm still doing open technique, and I still find this is a very easy way to do, and I have very good results, and I have no complaints so far from my patients. Leonard Brostrom actually published this technique in 1966 and then further modified by Gould in 1980. If you were to see, this is almost a 50-year-old technique, which has been so good, and I hardly have any much problems. Hamilton had reported about 93% success. There are mechanical studies done by Katie Lee showing it's as good and strong and sufficient repair in spite of doing separate repairs. Bostrom has got good outcomes. So advantage of Gould, why there was from Bostrom to Gould, it reinforces the ligament with the inferior retinaculum, helps limits the inversion of the talar, and corrects the subtalar instability. A good part is it does cover the Bostrom sutures. The old Bostrom sutures before there was anchor sutures was using loads of about 4 to 5 sutures to the bone and stitching it up. There was at least about 4 to 5 sutures repairing the retinaculum to the ligament. Now with the development of anchor sutures, I think the sutures don't come much into play. Then it also reduces the chances of osteoarthritis. This is the case that I did, and showing the anterior drawer test for the lady. And this is something which I find quite interesting. Where a patient under anesthesia, you actually can see the talar tilt on the foot is inverted, is rotated internally, and there's a talar tilt which I didn't put her on prone. The foot is internally rotated. As she's under general anesthesia, you can actually see the springiness of the good leg, and as well as the other leg, the surgery leg with this. This is the good leg, and this is the leg which is got a torn ATFL. It loses its springiness. It doesn't have the same bounciness as the good leg. And this is how I generally do my scope. And this is the instrument that I use now. Previously, I was using the Wynot RC rotator cuff. It was slightly bigger needle and also deeper penetration. After getting this the last 3 years, I've been using this regularly. This is the picture of her. I generally do an arthroscope. You can see the chondral lesion over the fibula, some impingement tissue over the medial malleolus with cartilage lesion. This is to show there's a tear over the AITFL, the sporting ligament, and there's a lax. As you can see, the ATFL is lax. A standard J incision is done to expose. I, however, do get a lot of patients with this fat tissue, which is protruding over the ankle in chronic instability. I do remove them because most of my patients tend to say it's a bit unsightly and they're not happy with it because cosmetically probably, but seriously, after the scar, you still have a scar, but they still want that fat, that swelling to be removed. After doing this, I generally remove as much of the fat as I can, and then I expose the inferior retinaculum first. I release it from the muscle underneath, and I look for the soft spot where the tear is, and now I do a linear incision and open up curved linear incision, and that's the peroneus tendon. I look for if there's any associated tear, and this instrument, I like this particularly because it actually does give you the, sorry, I like using the new CONMED instrument, which is the True Shot. The reason being it has got the K wire and it helps to facilitate the entry of the implant easily. Previously, we used to use a starter or a drill bit to go through, and this little thing has got a wire to facilitate before the implant goes, and it's actually a very handy instrument. And then let's just show, and just mallet in the implant, and you can see the particular implant going in quite. Oh, sorry for the cameraman. Apologize to that. As you can see, the implant is easily deployed. Getting it flushed. And then Esprit has got two preloaded sutures. And first I repair the lax retinaculum and the ATFL back into position with the foot in dorsiflexion. I do a modified Mason Allen stitch. I divide them into two, upper half and lower half. And I find the modified Mason Allen stitch gives me the best, and it's got the best strength and also durability. And after this, I proceed to placate the inferior retinaculum, bringing in. I tend to use the McDonald's just to prevent, not to catch the other sutures, just to protect my underneath sutures and bring in just the inferior retinaculum down to the periosteum. Similar, I use the same sutures back, and I divide the retinaculum into two, upper portion and a lower portion. Here is just to show that I don't want to catch the lower any other tissues from below. And after, again, the same method of stitching is using the Mason Allen stitch, and I tie them back to the periosteum of the fibula. So it actually gives me a two-band picture where you actually, after the stitch, there's a small modification you can see. I do modify it slightly, and after I tie the knots, I bring it back to the periosteum. So it looks like you have the, similar to the Arthrex internal bending, you actually have two, something like a fiber tape band to cover the periosteum. There you see the two stitch, and this is stitched right to the periosteum. This is stitched right to the periosteum of the fibula. So after that, I get that two nice looking strong band besides stitching the retinaculum in. All this is just using one anchor suture, and then finally I close the synovial sheet over the peroneus after looking for any tests or any other injuries associated. Sorry, and you can see this is pre-op and post-operatively. You can see the foot which is internally rotated. Of course, this foot is not suspended now, but the rotation-wise is corrected after surgery. Post-operatively, I do walk immediately with using partial weight bearing. I have not had any issues with it. They use a pneumatic shoe, and you can see they're quite happy with it. Generally, they all do partial weight bearing for a good 6 weeks, and then I put in an ankle brace for another 6 weeks. This is during when they are back to work, and they have to wear this for another 2 weeks, another 6 weeks back to sports training. And I recommend them to wear this at least for another 6 weeks to 2-3 months for when they are training for sports and when they're going back to sports. They can return back to active full sports after about 6 months of proper rehab and lateral strengthening. Thank you. This is my hospital. And now I would like to introduce Dr. Kim from Korea to present his topic.
Thank you. Nice lecture, Dr. Siva. My presentation is
Dr. Kim, I can't hear you.
okay. Do you see the presentation?
Yep. Can you turn on your volume, Dr. Kim, please?
Turn on. Okay. This is my. Okay. Turn on my. Do you hear me?
Yes, perfect.
Okay. Thank you. I'm Jinsu Kim from South Korea. I'm working on the Sejong Sports Medicine Performance Center. I'm a foot ankle surgeon and sports specialized orthopedic doctor. So today I will present about acute ankle ligament repair. Maybe we need the surgery in ankle, usually chronic ankle instability, but I'm today focused on the acute ligament repair. So my contents is firstly, do you need surgery in acute ankle ligament rupture? And second one is, if necessary, how should the surgery be performed? In the Cochrane review, there was insufficient evidence determining the relative effectiveness of the surgical and conservative treatment. It means we don't know what is better, both of technique. It's usually surgical or conservative treatment. Both of them will be effective in acute ankle ligament ruptures. But in the report, the operative treatment is better than functional treatment, especially in giveaway. So we usually see that the patient at the follow, they have some remnant giveaway, but they have no any symptomatic. So anyway, the surgery is better than the giveaway or the mechanical instability, but there was less better things is 1 week complication because of surgical complication, and return to activity period is very less than functional treatment group. And this is the randomized control study. The operation is better than conservative in giveaway, draw tests, and some functional scores. They Delayed in this case is delayed operation is similar result compared to acute repair, and favorable outcome from senior cases is mean is risk of complication, and operation need higher cost. So we can see that the reviewable literature, the surgery would be better, but it's not proven. We have a very small number of randomized controlled study and small number of patients. And the functional treatment is very successful, even just 70% successful. But mostly patient can be well after the functional treatment, including asymptomatic, even though unstable ankle. We saw this kind of ankle instability called the Gopal, but we don't know have any data of the long-term prognosis. And delayed operation also showed a similar result compared to acute ligament repair. So usually the conservative treatment is looks better than operation, but we have controversy. So in nowadays, every expert is agree about the operation in high-level athlete with grade 3 mechanical injury. So expert is told that we should be decided the operation individually. We need some hypothesis for surgical treatment. We need theoretical background. Why does it become to chronic ankle instability after ankle ligament ruptures? So we are surgeon. We are orthopedic surgeon. We should be doing operation. So we should be predict about the progression of the chronic ankle instability, and we should be stop it before the progression of the chronic ankle instability. So let's talk about the idea. I think how to use to catch the surgical indication. The example in ACL, after ACL tear, this is Crane's paper. They showed the natural story of the ACL tear. 42% is gone. There's absence in 1 year follow-up. And 38% is curving, 12% lateral wall placement, this notching area placement. So it's mean some structural changes. So the ACL complete tear itself usually a surgical indication in orthopedic surgeon. And other MRI study reported with intra-articular morphology of a toward ACL. They divide the two groups. One is this kind of mob type end tear and bony aversion, and ACL is retracted and completely resolved. There is some morphologically expected poor outcome. This class group A, group 1, and group 2 is intrasynovial rupture and attached to PCL and ACL and attached to each other, even though completely torn. So they reported as group 1 has poor outcome in the knee laxity. So they suggested this outcome due to the ACL placed in intra-articular surface and contacted with the synovial fluid, and the ligament cannot be breaching. So it could be related to chronic progression. So in ankle ligament, the ATFL usually inside of the capsule, but however, ATFL places everywhere is possible. sometimes the ATFL also intra-articularly place it. Maybe it's toward kind of this way, related to chronic progression. Yes, this is just theory, but it's not proven. And the Apinun also told that today's the anatomy is very developed. The isolated ATFL tear or inferior ATFL CFL complex tear or ATFL and CFL combined tear is they have different prognosis. If isolated ATFL tear has good prognosis, even though they are complete toward, they be completely restored. The ankle functional score mostly given have a 98 point. However, combined the ATF CFL tear has poor clinical score, even though they radiological telatility is not significant. So anyway, they article show that a combined injury maybe make a poor functional outcome. And we should be think about the anatomical characteristic. The CFL usually placed in intra-articularly 30%. So the intra-articular CFL tor also maybe cause to poor healing, maybe, yes. And another option is sleeve aversion. The sleeve aversion is totally popped out from the bone. There were bony side area is not a ligament. Here is fibrocartilaginous region. It's also difficult to heal at the injury site, and the bone to ligament healing, as well as ACL healing at the bone tunnel. So in clinical setup, we can easily diagnose this about bone ligament aversion tear. Here is the ATFL is toward from the fibula side. In my cases, MRI cases, 35% of ATFL is toward at bony side in chronic ankle instability MRI study. So in that case, we can see that in intra-articularly, the arthrographic finding, the upper ATFL is completely averted from the fibula side. I think that there is a good indication for arthroscopic ATFL fixation. Yes, we have nowadays the double ATFL theory. Not a theory, is in Korean people have got 50% have double ATFL. The single ATFL tear is make a micro instability. So it's just make a small rotational instability. It is it is need not prompt to operation. Maybe it's need to rehab, is make a good prognosis. However, inferior ATFL or ATFL and CFL complex tear, it make a major instability. So that kind of the major instability maybe need immediate operation. Is also make a good prognosis. This right side, the ultrasoundogram is here is upper ATFL part is wave is toward, but lower ATFL part is attached to fibula side. It is mean upper ATFL tear. She's returned to play 2 weeks. Just 2 weeks he can play. He can with just wrapping the ankle. He can play the soccer. He's a professional athlete. And the ATFL, the anatomy, especially distal attachments, is very special. ATFL is from the fibula to going to around the corner of the talus and attached to the neck of the talus. You know, see that this is the image transpire. So ATFL is going through the corner of the through the corner and move attached more distal area. If the aversion on this distal attachment, if the towel at the distal attachment, like this way, the left side MRI, the towel, the distal aversion tear, this corner is prone to distracted to distally, and so it make some big gap. So this gap of the gap is higher, and so it make to chronic progression also. This right side MRI scan show the fibula side aversion tear. Sometimes we can see that the same the MRI scan in chronic ankle instability also. And then this time we should be cut the fibula side and reattach to tendon to fibula bone. Here's subacute stages, and the ATFL is shrunken and displaced to proximally. We can see that the ATFL toward from the talar neck, and I can place it original site, and then I can fix it to that is original site with the bone fixation. I use the twist anchoring. So Takao is a very famous the ATFL guys in arthroscopic rostrum. He reported as the ATFL CFL complex tear is maybe reconstructed with arthroscopically fixed ATFL CFL complex. We so-called lateral ligament complex repair. Does it enough? I don't think so. Another Japan doctor, they told that ATFL, CFL, the functionally divided. Sometimes just lose ATFL, but several kind also as we can see in clinically. Both of them or just CFL, blah, 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 some things. So we have so many kind of variable loosening in the ligaments. And so the CAI progression, the hypothesis in anatomical setup, intra-articular tear, bony aversion, and ATFCF both side tear will also be possible to make a CI progression. You know, we need the data over the progression related to injury characteristics. This is my presentation in Korean Orthopedic Association. We suggested that the very severe type of the ankle ligament rupture in acute setup, especially CFL toward, not fibula, CFL usually toward calcaneal side, like ATFL toward fibula side, CFL toward calcaneal side. This MRI scan is 45 oblique coronal view. The CFL is toward from the talar attachment, and right side is completely toward and popped out outside of the peroneal tendon sheath. This is we so-call the CFL stand-like lesion. If just ankle sprain, maybe restored to anatomical position, but if severe sprain, it can be made there some standard lesions. So we previously reported that conservative treatment. In this time, we reported operation versus conservative treatment of calcaneal side CFL rupture. 22 versus 14 patient, followed with 27 months. As we check the proximal migration and the standard lesion. We usually the CFL rupture can be seen like this way. Every time, usually the distal attachment may looks like original attachment site. So we can see the video. ATFL is toward. I just opened the lateral capsule ligament. There is ATFL. There is inner side, upper ATFL is there. I just open slowly, and there is we can see that very loosened CFL, very loose. There is a move more than 1 centimeter. So we just the fold out, and then it can be pop out like that. So it's very strong and cord-like thick, the CFL. We can see that. So in kind of this way, the CFL is using the notice anchoring, make hole to the calcaneus. We fix it. We kind of bone fix. And using the two shot, if fibula side toward, we're using two shot fixed on fibula. If talar side, we fix it talar side. And the repair. Retinaculum, we just repair. It's not that full out. This two shot is technique. The two shot is a little bit. The first user is some difficult. The tip is very weak, so we stably fix. We drill on and hammering on there. The tip is hammering tip is not hammering the center. If you center is something is move, and so the axis is on here. So you hammering on this way. It's very easy, and maybe you avoid the kind of this complication. It's some error you make it. If you make an error, some the band tip, the tip, and so it's missed it. After CFL repair, the MRI showed the very loosened CFL. It make straighten the CFL. After 1 year follow-up, the compliant ankle instability score operation group is much better than conservative. And in terms of return to play is nearly same. This means conservative group also can return to their play. The stress view, yes, of course, talar tube much improved in operation group. The satisfaction survey, the surgical group, 86% satisfactory, but conservative is just 29%, and conservative group, 50% has unsatisfactory. So my acute ankle ligament, the ruptures operation indication, yes, we have controversy, but in my hand, should be elite level athlete, and he or she should be mechanical laxity in 4 to 5 days after injury, and in MRI scan should be grade 3 ligament tear, kind of aversion type, or ATF and CFL both tear, especially CFL side tear with proximal migration. Yes, it's next one is just variable. I show you variable operation technique. In acute setup, the ligament tear is very variable. It's not just mid tear, no. Sometimes mid, sometimes complex, kind of this blue jean tear like that. So we divided the ATFL mid fibula talar, also CFL rupture divided the calcaneal fibula complex. Just ATFL mid and calcaneal side is top tear. we see that the mid tear in MRI scan just lead end to end, contact to end. And CFL is toward from the calcaneal side, and it will be using the not the wrist anchoring the CFL, and the mid tear is just using a true shot and just repairing. And after surgery, the MRI scan show that the repaired ATFL and repaired straightened CFL also. And talar side, calcaneal side, it is you see the MRI scan. The talar side is distracted from the talar corner. In operation view, the talar side corner is totally ruptured, and nearly ruptured with articular capsule and ATFL also. And then CFL also is popped out from the calcaneal bone. And we have the subchondral preparation. We using the osteotomy, we chisel on about 10 millimeter and about 3 millimeter. We expose the subchondral bone and using the suture anchor and repaired. CFL also repaired with Nautilus anchor. And the end of surgery. And here also after surgery is good MRI scan. And fibula, yes, it's fibula also second place in acute setup. Fibula to fibula is very easy, but this is like a rostrum. So in MRI scan, completely aversion from the fibula bone. We see that very clean fibula tip. It looks like a cartilage. Inferior ATFL also toward the inferior ATFL, and CFL complex is toward from the fibula side. It's very easy, just decortication and using two sutures and fixation, and then we can see it's very good reconstructed ATFL on fibula side. And in this time, we prepare about the ankle breakage. If you don't make this cross, you should be the parallel fixation we need. If you cross, sometimes not the least anchor is broken. This mid fibula is another set of mid fibula. The CFL is not toward the calcaneal side, is toward fibula and distracted to distally. Sometimes make a deltoid also. We see the tear side. We using the suture anchor to repair the toward the ligament. So talar side on anchoring and repair. And CFL, in this time we loop beam the CFL and the loop to and tracted to fibula and fixed and repair. Sometimes we deltoid also superficial bundle usually toward at the malleolar side, but deep deltoid is toward at talar side. So it is a little bit difficult because of the very deep structure. But suture tech is very simple. We just see the small area and then we fix it the suture. So distracted the talar neck and we the fixed suture tech and repaired. It's deep deltoid, the toward from the talar side is repaired. So it is a little bit dangerous. You be avoided to subtalar joint damage. Yes, we are the last. Maybe we are now the last slide. The upper ATFL, talar, lower ATFL, CFL calcaneal, very complex. Anyway, we just make a puzzle. Yeah, everything make using the originally complex. Yeah. Maybe in this time we just repair with bike lane. Yeah, if we surgically treat, we just repair within 5 or 2 weeks. So if we have very various pattern, and so we need to choose various incision and variable anchor. However, if you treat it surgically in this immediately, we can make a very fast rehab. We just working just today we can working just 4 days. The rehabilitation start. We usually return to play. At the training is within 2 months, and he can do competition like a real game within 3 to 4 months. Thank you.
Thank you, Dr. Kim, for your presentation. It's now time for the QA. Any questions and questions, which we'll be gladly to help answer. Okay, one of the questions which was designated to Dr. Apinun. When doing an arthroscopic bostrom, how do you manage your portals, viewing and working?
Okay, if I use the anterolateral portal for viewing portal, and for working portal, I use the small step incision just underneath the fibula. I use the needle as a guide first to locate the step incision that I need to place on, and then perform the step incision and then work from it. Yeah.
How about the viewing portal?
Anterolateral portal.
Viewing portal is anterolateral.
Yes.
Antermedial maybe.
Pardon?
Maybe anteromedial or anterocentral portal in viewing portal.
No. Well, we can view from the anteromedial portal as well, but if we need to see really clearly for the ligament underneath, we sometimes need to go view from the anterolateral portal, and then that's why I need to use the lightly accessory portal by the step incision instead. Yeah.
Understand. Frankly, for me, is viewing portal. This anteromedial portal is very difficult to see the anterolateral structures. So I'm moving to anterocentral portal for viewing, and then we can see much more compared than anteromedial portal. So maybe anterocentral portal is enough to view of the anterolateral complex. Maybe you don't need accessory lateral portal, just make working portal. Yeah.
I'm scared of making anterocentral portal a bit.
Yeah, I know. But Dr. Takao and his group reported that the risk of the anteromedial or anterocentral portal. Yeah. It's me too.
Just like to ask a little bit here to Dr. Apinun and Dr. Kim. Do you use a 4 mm scope, or do you use a 2.9 mm scope for arthroscopic work?
Okay. For me, it depends. If it's just a debridement, I use 4 mm scope. But if we need to go inside into the central compartment, or perform the lateral ankle ligament reconstruction, which may have quite limited space because I view from anterolateral portal, I use a small, the 2.7 one.
Yes, for me, 2.8 maybe, 0.8 millimeter.
There's a question sent to me, I think, for whether removing the fat around the retinaculum. Do you guys routinely remove the fat around the retinaculum?
I never remove the fat. I am scared of the skin complications, so I try to keep the skin and the subcutaneous tissue as a whole flap.
Dr. Kim, yourself, please.
Yes, I never removed the pad. And usually
Okay.
I'm just told to my resident, please keep them all, because if you remove the pad, the retinal column is torn sometimes. We can't pull out the torn, so please keep them.
Surprisingly, I mean, I have not had any complications removing the fat, not even skin breakdown or sensory loss in that portions. But thing is, when we have some patients, especially ladies, they are very conscious with the ankle and they don't like that lump and bump around that ankle, especially in chronic cases. The fat tend to be quite a lot, and I do get quite a bit of chronic cases, and the lump around the ankle is very visible. Let's put it that way. So I do take it out for them. I trim it out for them.
Okay.
And I haven't had any complications. Dr. Kim, there's a question for you. Do you approach regularly people, non-athletes, who play sports in the same way as athletes? I suppose this is for those weekender players who are very active, who plays a lot of games on a regular basis. Do you approach them the same way as the elite athletes?
Frankly, in my clinic, we have so many athletes, but the not athlete, but they are recreational warrior athlete. So I usually take an MRI scan. If he complete toward same way. If you wanted to more return to play faster, recommend the operation. If like the CFL calcaneal toward like that. But usually, usual people, just 30, the woman is coming to me. I try to conservative firstly.
Dr. Kim, in athletes, if they come with grade 1, grade 2, and grade 3,
yes.
In elite, I'm talking about level of Olympic, SEA Games, or any further game, do you repair them in grade 2 and grade 3 immediately in acute settings? Because I do in those who come, those who are high-level elite athletes.
Yes. Maybe he got a severe unstable mechanical instability. After the 4 days, I recommended the operation. But in a clinical setup, they don't have not major instability, even though they tore the ligament, because they got a very strong the bone morphology, and he got a strong the muscles, and so sometimes very quickly recovered from the pain. They can work even after 4 days, and then we using some functional test. Maybe he can work. Maybe he can small jump, single heel lathe, and then I tried conservatively first and some injection or some things. But if you have mechanical or unstable instability, I tried the operation.
There's a question to Dr. Apinun. Arthroscopic was mini open, pros and cons. I have no experience in arthroscopic. From what I know, can you all please elaborate a little bit on this, please? Arthroscopic versus mini open.
Well, for me, I don't do for me, I don't do the mini open. If it's open, it's open. So for arthroscopic cases, there's a benefits in early return and less pain. However, like in my talk that I mentioned previously, that I'm kind of selective about the case that I will perform arthroscopic repair, that the instability must not be so severe, and the ligament must be in a good quality. That's the case I will perform the arthroscopic repair. But if there are some risks of failure that might happen, that I would perform open or convert to open procedure.
Yes, I'm also completely agree with opinion.
It's just that a little point to add. Arthroscopic has got a longer learning curve, and it has got also choosing the candidate, like stated clearly by you, is very important, I think. And there's another question here. In arthroscopic repair, have we ever had a problem about ligament retraction that could not bring ligament to original position? How would you deal with it?
Okay, I think I think it's my question. Okay, first, because in my way of repair, first I put the suture first as a shuttle. At that time I put the suture already. I can feel, I can sense the flexibility of the ligament. Also, we can use like grasper to assess the flexibility if it can be brought up to the insertion. If it cannot, then it must be converted to the open procedure. We have to talk to the patient before the operation every time that there is a chance to convert to open. Not always successful. Yeah.
I have some ask question. Also, you, the doctor. You show the open brostrom procedure, both of you. You looks like repair the anterolateral complex. I think do you confirm the real CFL bundle inner side of peroneal tendon, or just anterolateral capsule repair?
You mean?
Yes, Dr. Apinun, you go. Carry on first.
Pardon?
Dr. Apinun, you answer first. I'll follow.
Okay. I mean, do you repair the CFL separately? Do you repair the
No.
CFL and repair CFL?
Okay, I detach the whole flap. I start from above the insertion. I detach from the periosteum and down to the whole flap of the ligament. Then I tighten the whole thing up to.
Okay.
I fabricate. I still follow the old Bostrom technique. I fabricate the whole thing as one piece together, but I divide as the suture by True Shot has got two limbs, so I divide one limb for the ATFL, the other limb for the CFL, and I tie them together.
Tie them together. My senior professor, the KT Lee, he's very famous sports doctor. His brostrom is single ATFL brostrom and with lentanacular repair. So he told that the lentanaculum is function as a CFL load. I feel that, but in nowadays, I completely divided the ATFL bundle and divided the CFL bundle. And so I repair CFL bundle to fibula tip and repair the ATFL bundle or anterolateral complex to the fibula tip. And then we don't need lentanacular repair anymore. So maybe the CFL bundle repairing is a little bit technically difficult, but if you make a real CFL bundle is reconstructed to separately, and then you don't need any periosteal flap or the lentanacular repair. My opinion. Some strong sentence. I'm sorry, it's my opinion.
Yeah, it's better to be anatomically reconstructed. That's why I use two anchors, first at the anterolateral and the other one at the tip. So try to reproduce the ATFL and CFL insertion. Yeah, and for augmentation, I think it's just about okay, the retinaculum is sometimes it's about the proprioception, or probably it depends on how you create the scar tissue to have the tissue a little bit more robust. Also the periosteum. Well, so okay, if you perform more acute cases, I think the quality of ligament is enough. But in some cases, it's really thin and the quality is so poor. So in those cases, I think the augmentation is still necessary. Well,
Okay, yeah, all right.
I think that is better because the chronic cases which we get are generally not as strong. The tissues are not that good. They have already gone through repetitive trauma. They're so lax actually. I think augmenting in chronic cases will be very much helpful. In acute cases, perhaps just doing ATFL and CFL separately is much more anatomical and helpful for the patient. I agree with you on the acute part. Do we have any more questions from the floor, from the viewers, participants?
may I ask Dr. Kim, from your presentation, you told me that the interval that the timing that you would perform the acute repair was up to 3 months, right?
No, 2 weeks.
Or 2 weeks, sorry.
Yeah. Yes.
It is after that time. What would you do with the patient? It cannot be repaired accurately anymore. Do you treat them as a in a rehabilitation way first, or what do you do with them?
Yes. Within 4 weeks, sometimes I'm tried the operation, but after 1 week later, they are coming too lately, and then I tried rehabilitation first because of in terms of return to play, he returned to play faster with the rehab, even though he have unstable ankle. So it's very difficult timing is after 1 month to 6 months within that period. Very difficult for me. It's just rehab, but he have got a pain, but rehab, and we need important to best return to play.
Okay, thank you.
Yes.
Dr. Apinun, keep the question here. Do you guys use routinely in chronic cases? You try to repair first, or do you use a graft, hamstring graft, for augmentation in chronic back cases? Would you try to repair primarily, or would you go in and use graft when there's absence of ATFL and CFL?
Okay. Depends on the quality of tissue and also the generalized ligamentous laxity, and also the BMI of the patient. If it's a high risk case, like those patients, or the really poor quality ligament, I would perform the reconstruction.
What will be your diameter of your graft you like to use? Would you use the semi-T or the gracilis, if you don't mind, if you're using a hamstring?
Okay, I prefer the semi-T. It's a bit big, too big sometimes. Yeah.
Isn't it? So I suppose you anchor with tenodesis screws.
Well, I don't think so. I think because I put it at the anatomic position, so it shouldn't count as a tenodesis. Tenodesis is we use a tendon and still has the origin of the tendon at that place, so not count as tenodesis.
Don't you? I mean, semi-T is very thick. What about you, Dr.
Me?
Kim?
Yes, I'm usually very poor quality and very unstable and bigger guy like a basketball player. I'm usually using allograft semi-tendinous and using the tenodesis screw.
But a semi-T is at least about minimum about 6 millimeters.
Yes, usually I make a drill hole 6 millimeter, and that is enough to tendon and tenodesis.
Don't you find it too? My question: why am I putting this question? Is one of the complications is being too rigid of a repair, and arthritis. Although it's anatomical, the grafts are too thick and they are not going to elongate as how they are supposed to be. It's much more thicker than natural graft. That's why I'm asking this question.
Well, the size is one thing, but the rigidity of the repair is not only the size, it's about the tension that you set. So we set the proper tension and we make sure that the tension time that the graft, even it's big, it's not interfere with the ankle motion. It's fine.
It's for the ATFL, just the mosquito technique. Just fibula-to-talar side, the same internal brace. You have one mosquito inside, underneath of the allograft. I fixation that is not too tight. And so for me, the soccer player, the subtalar joint is very, very important. And so in soccer player, I just ATFL reconstruction, CFL repair. But the basketball player is sometimes very, very, very problem. So the Y shape, the allograft reconstruction on fibula to talar and fibula to calcaneus. In that time, CFL little tightly fixation, but the basketball player, they need that because of there some kind of jump and he needs strong stiffness. So I just my indication is different soccer player and basketball player. In usual people, I just reconstruction ATFL alone is better. They are very feel that the free than post reconstruction.
Okay. Since there are no more questions, I would like to thank both of you for this wonderful presentation. On behalf of Dr. Jirun and Dr. Kim and myself, I would like to express my appreciation to the organization to give us the opportunity. And I'd like to thank all the participants for spending their Saturdays with us to listen to our sharing all these valuable tricks and pitfalls. I'd like to thank CLAAS to help out in this making this as a possible event. And we would like to please excuse us for any shortcomings that we might have, and we welcome for any feedback. Thank you very much. Thank you very much for CONMED for the support given to us.
Thank you.
In the future, and there's also something like CONMED has many more webinars installed in 2001. So please check into the website and look into one. There's one coming, I think, next week or 2 weeks from now. Guys, thank you.
Thank you.
Thank you.
สวัสดีครับ